reason most were not involved in the research and scientific publication. But now in new era, any article you type on Google or some of the website, the Russian website, it will be available. So the now information is not an issue. How to use the information, that is very important. And the if you divide the reading of the paper, if the person read the paper for first time, it would be different than you do the reading of a paper in a journal club. If a reading by a researcher would be entirely different because he wants to have some points which is relevant to him. And the most important reading by a reviewer, because a reviewer would be a very critical for the what you write about the paper. So it would be entirely different from the first time to the reviewers, depends on the experience of the person. It would not be the same for the all. But for benefit of the all, because we have the heterogeneous group, we will see the for the first time to the journal club how to go ahead with the research reading about paper. Because I know the Maulin is doing about the journal club, so we'll have some of the points what is to be useful for the journal club also. Why it is relevant? Because the 20 years back or the 50 years back, the science was on the expert-based evidence. Now it's become expert-based, become the evidence-based, because anything you say that you do this or you do this technique or this treatment method or non-operative method or the operative methods, somebody is going to question that where is the evidence. Unfortunately, some of the rare condition in the pediatric orthopedics still it based on the expert base, not on evidence base, because it is practically it is impossible and unethical to do some of the research like a randomized control trial. Because I have come across, say somebody has started doing about the Ponseti versus some other technique, Ponseti versus the kite technique, and the reviewers and ethical committee has thrown that paper that say this is unethical to do because something has been proven already for the treatment. But again, if you want to know about the advancement of the science, it must be evidence-based. There are some of the question that are also unanswered in the Ponseti area, like how long we need to keep the brace, what is the ideal duration, what is the ideal discarding time for the braces. And such area needs actually a good high quality research paper. Coming to the point, what the scientific research entails, asking a relevant question. And that is the most important aspect of the scientific research reading a paper. Because what is required, if the author has described the relevant question, it is good. But if it is not described, that the reader must find out what the question the author is raising. And what is necessary to find out the rational answer to the question by investigating a problem. And that is very necessary, because the scientific methods, the paper based on the question, whether that is a rational answer to the question by investigating problem. So what is required? It's required to have a very good methods employed to answer this question. The main crux of the research article is the methods, not about result and interpretation and discussion. The most important aspect of reading a scientific paper, what question the author raised and what methods they have used to deploy that answer the question. That is the most important. And after raising a question, materials and methods, whether the documenting the result of this investigation, whether that is proper, whether information is adequate or not, that is required. Most of us are aware what are the structure or anatomy of an article, includes from the abstracts, introduction, aims, methods, results, and discussion and reference. The most of the people, almost 75% of people, will take the information from the abstracts. Yes, that is important to know whether the subject is relevant and important for you, but you cannot extrapolate the evidence and the quality of paper only from the abstracts. If you want to judge the quality, you need to read the entire text. Unfortunately, every single surgeon will not have time to go through the number of the publication, because the number of publication has gained a lot of popularity and the number in recent years. So it is practically impossible to go through the each and every article. But the subject of the importance means, suppose you are interested to do some study or should research on that, first read the abstract and get that idea what kind of paper it is, what kind of evidence it is, then go and read the entire paper. So we'll come to the point, what are the most relevant and the important points. The most important is that reason for undertaking the studies. We need to find out what the author says about the aim and objective, primary aim and objectives, what the current literature says for that topic. The review of the literature for that topic is very important, and what are the methods. We'll go in one by one. So when we read the introduction, we identify the what information is already there at present in the literature and why the author or we have chosen this topic that is important and relevant for the introduction of the paper. And the most important and necessary, what the current literature's knowledge says, whether that has been quoted or cited in the introduction, that is very necessary, because sometimes some questions are already answered, whether the author has done a similar study or something new. It depends on the introduction. We can come to know what is the relevance of the study and why the study has been conducted. Reason for the study we need to find out, and that is to be quoted in the aims of the study. We need to find out whether the author is very specific for the specific aim for the study, whether it is specific aim is defined or not. Sometimes it would be very vague, and whether they need to find out about the question to is stated or not. Many of the articles do not state about the question. Question means that is a hypothesis of the author. Again, this is the most of us learn that in community medicine and preventive and social medicine, the hypothesis, null hypothesis, but it was be really dull in the PSM and community medicine. What is the hypothesis? But in a simple language, we can say what is the hypothesis of the study, whether this is associated with X. Like if you do the study about the clubfoot, whether my hypothesis is there, is it important to do the bracing after 4 years? So that is very relevant point. What is the necessary endpoint for the positive bracing that we want to search it, something like that, whether the question is asked or not, because sometimes the hypothesis is not written in some of the article, but we need to question ourselves and find out whether the hypothesis is there or not. After the hypothesis, whether the person has done the perfect materials and methods, and what is required. The first, as we said, the hypothesis, then it comes for the selection of the patients, then the data collection, the analysis and interpretation. We'll go one by one. What is required to know about the population? What is the study population? Actually, the study population depends on the subject of the author's interest, whether the actual population, the case population is representative of the entire population, whether the characteristic of the patient population is well described. Characteristic means not only the demographic characteristic, not only that, whether they are true representative, because the population of India may face a different sort of the issue than the Western world. Like if you see about the infection in pediatric orthopedic is very, very common in India and some of the developing country, where the post-septic sequelae is extremely rare. I'm not saying it is totally uncommon, but comparative to that, frequency of the incidence or frequency of the post-septic sequelae is more in India than the Western world. Western world do see some of the trauma, whether like the high energy trauma, like the sports related injury, and compared to them, we do see a less number of the patients with the competitive sports. I'm not telling that totally not seeing that, but it would be different. So whether the characteristic of patient population are well described or not, whether the pathology means diagnosis of the condition is present, and how the diagnosis was made, that is also very important. The definition of the diagnosis or definition of the patient population is must, because that will reduce the confounding factors. Because if the definition of the patient population is not very well described, you can merge. Suppose you will say the case of the clubfoot, that would not be adequate. We can say the case of the idiopathic clubfoot, means it is we are talking about the only idiopathic clubfoot. We are not talking about the non-idiopathic clubfoot. So it would be very important to say that characteristic and definition. Then the inclusion and exclusion criteria. Suppose we'll say the clubfoot means we want to say the brace ending at 4 years, then we need to say with all the consecutive patient of the clubfoot till 6 months of age were included. And what are the exclusion? That is also very important, because those demographic data and inclusion and exclusion criteria may affect the results and interpretation. Is the description of the baseline characteristic here? The baseline characteristic is important when you do about the comparative study. Suppose you will take the one group of patient with brace and one group of patient without the brace. So we need to say as baseline characteristic are comparable and relevant. Like if you take the child with clubfoot with very less severity, the Pirani score would be very less, and you treat without brace, and severe patient with more Pirani score, you take patient with the brace, and you take about result and say that at final follow-up, the outcome is same. But that is not relevant, because the characteristic of baseline characteristic would be different in the both group, and the analysis and interpretation is totally irrelevant. So the description of baseline characteristic are sufficient and comparable in both groups. That is also very important. Next comes about the design of the studies, the most important aspect of the paper, because as we know about the level of evidence goes from the expert opinion to case report to the case series to the retrospective, then prospective, randomized control, and meta-analysis from the bottom to up. So it is very important and necessary what kind of study we see that. Is it a prospective study or is it a retrospective study? Prospective study, it is important that the study population and outcome is over before we start about the searching what is relevant, searching about the question of the hypothesis. Where the prospective, you generate the question and try to find out by doing intervention or diagnosis. That is a prospective. So that is most important, because many of people would be confused between the prospective and retrospective. Similarly, the control and cases and a prospective. It can be the prospective comparative, it may be retrospective. Suppose you take a both group and the treatment is over, the outcome is also over, and try to study in between group, that will be also comparative retrospective. But you say about the intervention today and find out whether the difference in a clubfoot, that would be prospective comparative study. Again, the prospective will have more weightage than the retrospective study. Unfortunately, every study cannot be the randomized controls trial, but the most important of the material and methods, the data collection should be reliable and through a proper the linkage or records or correct surgical records or structural pro forma of the interview. That is the most relevant aspect of the study design, and it would be the identical and same for all the patients. It cannot be one patient you do something and second patient you do about the investigation of something. Then the quality of the material methods would be less. It is important to have the sample size calculation. If you compare, if you do about the prospective study, in retrospective study, the sample size calculation will not come in the pictures. But if you do about a retrospective study, the sample size is not important, but prospective it's always, because you need to say, and the sample size depends on many of the postgraduate will come and say we went to meet the statistician, but the statistician was asking. Yes, it is very important to ask the statistician for the sample size calculation, but the statistician will ask you the two values, alpha value and beta value, to reduce the two type of error, what we learn in the statistic. In fact, they will say that as the power is higher, the study quality is the very important, because we can find out the minute difference, and almost all know about the p-value, but it is important that the p-value is 0.05 significant. That means the 5% difference we can able to analysis. That is important for the prospective study. Another aspect of the pediatric orthopedic study, the follow-up period is very important. Whether the follow-up is adequate and it is defined or not, whether the time is the timeline at the last follow-up, whether it's 2 years, 3 years, the most of the study should end at the skeletal maturity if we are dealing with the pediatric orthopedic. But the many of time it may not be possible. Practically, it is not possible. So when you read the article, what is the follow-up? Because the growth is not over. If you read the article at 1 year or 2 year or 3 year follow-up, then whether you need to ask yourself whether if it is a trauma subjects after 2 years, it may not be relevant. It is not required to do the cases to be studied at the skeletal maturity. But yes, if it is like the Perthes disease or a DDH or a growth abnormality, the growth would be affecting a main factors. Then it is practically, because many times people will write about DDH 2 years later, the results, but it may not be very relevant, because you may find the growth abnormality after 5 years or 10 years following the surgery. Then it is very relevant for the follow-up of the period. The studies design, as I said, is that it's a prospective or retrospective. The most important aspect is that outcome analysis, whether the outcome is the measure is relevant to the primary question, because the most of the studies now move it to the patient reported outcome. Again, it is not very popular and common in India to have the patient reported outcome, but it is not always a patient reported. Outcome means maybe the clinical outcome, radiological outcome, functional outcome, but whatever the outcome that would be relevant to the research question, whether that is the standardized or the validated outcome is used. What I said about the standardized and validated, like if you see about Harris Hip score, the originally Harris Hip score is described in the blocks, that may not be possible to use in India. Then if you want to use in India, you need to have the kilometers or meters, because it has never been described any distance in a block. So some of the times we take it from the Western literatures, but it may not be relevant because it should be standardized and validated in our own population. The timing of the outcome is very important, because if one group of the patient, if you do the analysis at 1 year and second group of patient, we do the analysis at only 1 month. So it is not relevant to compare the both groups. So both groups timing should be similar. Important aspect of the study, the author must be very honest to report all the adverse events. Any particular disease would not go without the complication. If the surgeon says or the researcher says, I don't see a zero complication, that induces the suspicious. Because in science, if there is a reported 1 to 2% or 0.1 to 0.2% of complication, it may be present. It cannot happen that without the adverse reaction, may have the complication, may have the not proper outcome. So it is very important to know about the adverse event described or correctly attributed to LO. And it is important to learn from the complication of others. Why does it happen and what is the reason for that? And we can prevent and that. So whether it's a categorized or not, whether it is important. Whether the compliance is acceptable in all group means sometimes there would be dropout of the study. So if you see about 100 subjects and at last you report only 20 patients, and that is reduce the reliability of the study, because 80% of the patient would be dropout, whether it is acceptable or not. Most of the time, up to the 80 to 90% follow-up would be necessary to report the patient. Another aspect was there who collected about the data, whether the the data collection or the researcher is blinded to the subject, whether it is validated, whether it is uniform protocol is used for the group of patient or cases or not. That is also very important, because if some patients, group of patient is treated with one protocol, other group of patient is treated with other protocol, then it will not give a correct and right message. Coming to the result and interpretation, whether the before the result says whether the appropriate statistic, again the statistic is the one, because I silently excluded statistic. It is one of the boring subject for the first time if you say that. But if you are having the normal biostatistic knowledge, like from the MBBS, you can say categorical or a continuous variable, and you can have, there's a very good article from the Mohit Bhandari. If you are very new to the statistic, I say urge you to read only one article. It's not he's having full volume of the JBGS, but and second is one full volume of the Indian Journal of Orthopedics. He has written prospective, comparative, RCT, meta-analysis, all the guidelines. But you can read what test should be applied for what group of patients. So that is whether it is sufficiently described or not, and whether it is applied or not, and whether it's appropriate test. Because we need to say, people are not familiar with the statistic. They will say whether this is Man-Whitley test is there, whether it's a bad T test is there, whether this is the logistic regression, the biphasic logistic is some comparative study, whether this level of significance in proper test is applied or not. That is to be seen that. And whenever there will be randomized controlled trial, whether intention to treat per protocol is there or crossover between the groups, it's been identified and reported or not. Sufficient numerical information provided to the authors or the readers is there or not. We need to find out on that. How to interpret that, whether the conclusion are really supported by the data, whether it is sometimes the interpretation is something else and data says something else, whether it is relevant or not. And that is the duty of the readers. When we read about article, we need to say whether it is relevant or not, and whether the author mentioned about the limitation of study. Any study you do that, you plan some important study, but there would be some limitation, always a limitation. It's a great effort by the authors, but sometimes always there would be some limitation, whether they have been quoted, cited and mentioned or not, and whether the author have used about the correct reference to the current literature, or the conclusion derived from the study analysis, whether you can say that study is designed well and conclusion is related to the existing knowledge, and whether they add anything new when study is worth or not, that we can find out on that. So the few points for the journal club, when we do about journal, I know that Maulin's interest was there to have this journal club, how to have an effective journal club, because the journal club is going in all over the world and it is not a new concept, but unfortunately in India it was not followed for 100 years. And I am happy that many of the institution and even in non-institution we started having journal club. The journal club is one of the effective ways to have the scientific communication and enhance our knowledge. We need to improve our knowledge by the journal club, what is new in the literature. So we need to cite that what is the specific purpose of the journal club, whether we want to go with the technique, whether we need to do with the new in literature. We need to find out why we are doing about journal club, and we need to have a time frame, whether it is once or twice, or whether you'll have the once in a month or once in a week, that we need to define that. And should have a team leader. I know that Maulin is leading in this group, but then it should, sometimes the team leader would be different in a different setup, because the team leader should circulate one of the important, choose the article, and why you need to choose the article depends on that the area of interest. He will choose the article. So he need to choose a proper article and circulate all the readers, all the attenders, that what articles we are reading, so they can actually read about article and involve into the effective discussion, and use the established way of the critical appreciation. What I have described is based on my knowledge, but that is definitely multiple guidelines are there, Prisma guideline, CARE guideline, STROM. So many guidelines are there to evaluate about the paper, whether it is a structured worksheet is available, and this all are free in the Google form. You can say that, and at the end of the single or two article in hours, we can have a healthy and productive discussion. What are the strength of the study? First, we need to be very critical for the all articles, because the authors did spending a number of hours to do some research. So we need to find out what actually he wants to convey, and the strength of the article and the limitation of the article, and that formally we need to do about conclusion. The end of the day, we can say about that whether it is relevant for our patient population. It is whether you can change into the clinical practice. That's, I will tell very simple. Whenever you read about the paper, you need to find out what is new in the paper, whether the understanding of our understanding mindset has changed after reading of a paper. Does it apply to our population, whether it is useful or not useful? Sometimes it was useful, sometimes may not be. The important to find out what is the strength of the study, important to know what are the limitation of study. And again, limitation of study is not only critics to the authors, and that will give you the idea whether you can do a same subject study to enhance the understanding in the future, and what can be done if you do a research in a same subject in a same topic. And the most important and relevant question is there, do we change a practice after reading of a paper? If it is say yes, that is a very well cited, very well important paper. If it is no, we can keep it in that it may be useful in the future. Okay, I will end my talk here. The question I will answer.
So that was a nice summary, and it echoed what I tend to teach my fellows. I remember one incident. So I learned these journal clubs from my training in sick kids. And I remember we had a journal club on classification of Perthes disease. And Robert Salter was sitting besides me. And we were also discussing Salter-Thompson classification vis-a-vis herrings and lateral pillar and this modified Elizabethtown. And in sick kids, the prerequisite to become a staff is you should have your master's in epidemiology. So most of the staff were quite strong in the study design and all these epidemiological aspect. And at the end of journal club, they were so bold to say that Salter-Thompson classification is full of fallacies, and you know they brought out those points that we cannot classify. And so Robert Salter was just sitting there, and the young fellow said that this Salter classification has this limitation. So what I learned is journal clubs with your knowledge in epidemiology makes you bold enough to not only criticize, but to accept that not all published data is relevant or true, you know. And that is the aim, to train all the fellows that you will read a lot of things, but make sure that what you read is studied in a proper way. As Hitesh mentioned, we do not have incentives in most of the centers in India to publish papers. It's just your interest and your desire to contribute to the literature. But in Western world, there are incentive to get hierarchy in their academic post, and so we see lots and lots of papers coming up, different journals coming up. We are receiving a lot of invitation to send papers, and will get accepted in few days. So in this era, everyone can swear by their technique by presenting one or the other paper. So I want to make all my fellows robust enough to understand what is right and what is not. And Hitesh's talk is very nicely, he has mentioned this. So we have the same guidelines, Hitesh, while we read that how it is structured, and at the end, whether it is relevant to our practice. So I concur with you. We would be grateful, if you give us a small, a brief, what do you say, a template kind of that. How would you ask your fellows to read, and they tick mark, they okay, the study design is okay, the number of patients are, the power of study is okay, the way the data has been collected. So if a template, so that we can apply to all our articles, and that is a kind. Currently what happens that the fellows read a paper and they read the limitation of the papers in discussion, and then they highlight that these are the limitations. But I want them to read between the lines, and they should come out and ask question that, sir, is this the right thing? Because the number of patients are so less in one group compared to the other. So I think of a template kind of thing which you give to us, and they would apply it to each articles they are reading, then it can be a great use. How you made your fellows to read these papers more reliably, and you made them more critical, Hitesh, in your practice?
Actually, we do have in our institute, we are having teaching college. So in the postgraduate, read the papers. So I always say that when they read about the paper, they need to not mention. See, most of the time, postgraduate, what they do that they just do copy and paste from the paper. And whatever the author has mentioned, that they can mention the same in their presentation, but it is not actually the way of dealing with the journal club. So if you want to deal with the journal club, we can have maybe 1 or 2 articles, not more than 2 articles. Then neatly have the time for the half an hour, and it should be circulated with all the fellows or all the attendees, including consultant and all, and they can read actually the critical points. What I made it a template that they need to say what, as according to my talk, what I said, that what is there, the introduction means what is the current knowledge, why they have done the study, what is the aim of the study, what they will say the aim, the methods are related to the aim of study, and the same whether the results and interpretation are related to study. Similarly, when we have that is a stipulated whether it's a retrospective or a prospective. But as I said, it is not practically to have the every single condition to the RCT, and I don't go with only the evidence base like the RCT. Sometimes a very rare the case scenario, like the very rare, once in a while you see like a valgus slip, the very rare where you can't have even the slip capital femoral epiphysis, there is no randomized control trial. Then, so if this is the new topics, I will make them to search the literature and get the knowledge on that. If it is the existing common topic like a clubfoot, we need to stress more on the methodology, like whether that is study design is appropriate, retrospective and prospective, what is there. And I always say that they need to write what you understood, the strength of the study, at least the 2 points, at least a 1 point, not about 2 points, at least 1 point. And then the limitation of study, not the limitation of the authors describe. What did you find it from one article? I remember when I joined 2003 here in Dr. Benjamin gave me one article to read and say, find out the limitation of study. And I can say it can come with only the experience. As you read more and more paper, you read the more and more paper, because if subject is new for you, you can't find out the limitation. You need to say that this is so it depends on the experience of the person. We need to have and if the fellow is unable to answer some of the limitation of study, the team leader or the other associate members can discuss whether is it like this or whether it is like that. So I think the effort should be given from the presenters, and other people can give their inputs. So, but if you want the template, there are the ready-made templates I can provide you. That is not an issue.
We can invite you in few of our journal clubs, or we can arrange them at your convenient time, and you can see the process and guide us.
Yeah, no problem. Fine.
Right. So I think thanks, Hitesh, for that wonderful talk. And I'll move to my talk now. Where it is lying, let me see. So can you see my slide?
Yeah.
Okay. So let's discuss this paper, factors affecting the outcome of chronic osteomyelitis in children, which got recently published uh, in International Journal of Pediatric Orthopedics, which is our own journal. So we have been studying this topic since long, and this was due to the lot of patients coming to us in a neglected form of bone infection. So let me go to the subject right away. So these are young children at almost 16 months presented with panosseous osteomyelitis, and child was treated with decompression and antibiotics administration. And at the age of 2.1 year, there was uneventful restoration of bony architect. So this was a proximal tibial chronic osteomyelitis. And this is a similar child, a little older, who had multiple surgeries for proximal tibial osteomyelitis, and who ended up into a sequestration and finally a gap non-union. So a treating surgeon, when he's presented with a chronic osteomyelitis case, he is heading to two broad ends of outcome. So it can be a completely restored anatomy of the bone at the end of treatment, or it can end up into a gap non-union, And so being a young orthopedic surgeon, I always question myself that why the outcome is different in same presenting child, or what are the factors which can forecast that this patient can head to an adverse outcome. Because when there is disparity in what you explain to the family, there always will generate conflicts. And so too, I thought that there is a dire need to answer these questions to prevent any conflicts in our practice. So with this background, we tried to study, and the purpose of our study was to identify the factors associated with adverse outcome in children with chronic osteomyelitis. For this, we did a retrospective analytical study, and we had 40 consecutive patients treated at our center between 2006 and 2012 with a diagnosis of chronic osteomyelitis. And the age spectrum or demographics were ranging from 1 year to 14 years. And average follow-up of those children were 2.5 years, ranging from 1.5 to 4 years. So in materials, the basic data and workup, we inquired about the detailed history about previous treatments from the patient's existing records, and when needed, we inquired with the treating index surgeon also. We also noted down their blood investigations, culture reports, and local x-rays. And before embarking on any treatment, we got MRI of the local part in all our patients to guide our treatment. Now, how MRI helped us, or we made the decision, MRI always gives a clue about the extent of intramedullary edema or intramedullary abscess. Now you can see in this child, there was only disease in the proximal metaphysis and some periosteal reaction on presentation. But when we got an MRI, we can see there is edema extending all across the diaphysis, and there is collection into the distal metaphysis with a sequestrum here. So this is what I term as a steep lesion. Just a moment. Manish bhai. Hello. હું એક લેક્ચર આપી રહ્યો છું, આપણે વાત કરીએ, તમે નીકળો ને પછી વાત કરીએ. So first advantage of MRI is it gives us the extent of intramedullary edema as well as abscess. so that you can decide upon how much decompression you need to do, whether it's just localized to metaphysis or it's a pan-osseous disease and you have to deal with the whole medullary cavity. It also gives a clue about the associated soft tissue abscess, which is it a focal unilateral abscess or it's a circumferential abscess, and whether it is a single compartment or there is multiple compartment. So we got MRI in all the patients to decide our line and extent of management. What methods? We did local debridement in a localized metaphyseal disease with or without decompression medullary canal. If there is a pan-osseous disease or there is a steep lesion distally, we would decompress the medullary canal, and it was followed by plaster splinting. Injectable antibiotics were given for 5 to 7 days, and it was followed by 6 weeks oral antibiotics. Now remember, this paper was created in the era where stimulant beads were not available, or cemented beads with antibiotic impregnation was not readily available in our practice. How we decompress the medullary canal for the long bones and where the excess was easy, we used forearm reamers, and at places where in a very young children where it was difficult to negotiate, we used the giggly saw wire. And now in our practice, we have been using giggly saw wire assisted decompression very frequently, and in most of the patients, young or old. So I will discuss that part later. Role and technique of giggly saw wire assisted intramedullary decompression, I'll talk at the end of this paper. In methods, we used external fixation with or without intramedullary nailing in patients with pathological fractures or gap non-union. Those patients who did not have pathological fractures, we just decompressed and debrided and given the splint. But patients with pathological fractures or gap non-union, we use the external fixation. And at times, we use an antibiotic mixed cemented nails in a few patients. So this was the 1 year post-surgery of one of the patients with infected gap non-union. So we have used external fixator, and the nail was exchanged with an antibiotic mixed nail. And once the disease there was no signs of active inflammation or active infection at the site, we did a second stage bone grafting. Now, based on this treatment, the outcomes were defined into 3 groups. The good outcome was defined as uneventful healing after primary intervention. So only 1 surgical intervention was required to restore the normal bony architect. The fair outcome was the uneventful healing of the disease, but the patient required secondary procedures to improve the bony architect or joint motion. Like some patients require a sequestrectomy, a small part of sequestrated bone required removal, or some patients who had femoral osteomyelitis had stiff knee and we required to do a quadricep plasty. So whatever the patients who require second surgical intervention would be rated as a fair outcome. The poor outcomes were the ones where gap non-union resulted. So the distribution of outcome in this 40 patients, we have 45% patients had good outcome, 30% had poor, and 25 had fair outcome. Now, we'll just give you small examples of this. This boy had an proximal tibial osteomyelitis with some reaction to the drug and rashes all across the body. The pus was discharging after primary treatment done elsewhere. This is an X-ray showing signs of osteomyelitis, and this was an MRI, and we did a double level debridement and window and decompression, and this child eventually healed up well, and there is a 3 years follow-up. So this was only 1 surgery was done at our center, and child did well thereafter. So this was defined into a good outcome. Similarly, this 2 years old boy who had pan-osseous tibial osteomyelitis with extensive abscess, as you can see, and we debrided it, and we did the giggly saw assisted intramedullary decompression. And on follow-up, we found there was sequestrum formation on the posteromedial side, and we splinted this child. gradually the sequestrum got organized and there was a small sinus, and we had to excise the sequestrum, and child did well thereafter. So this child required one more intervention and it was classified as a fair outcome. While this boy, which I mentioned, the 6 years old boy who underwent 3 previous surgeries at different centers, presented to us with a sequestrated diaphysis, and it ended up into a Lizaro fixation with debridement. And then once the wound got dried up, we, as per Sandeep Patwardhan's paper, we did fibula interposition grafting and cancellous grafting. Unfortunately, that also got infected, so we had to remove that fibula graft and did distal corticotomy and translation. And after docking, the bone was restored, the anatomy was restored. So this is 5 years follow-up of this boy. So although the outcome, the final radiologic outcome and clinical outcome is good in this child, but still, as the child required series of interventions, this was reported as a poor outcome of primary surgery. And this is the video of the same child who was 11 years, 5 years down the line. So as you can see, functionally, he improved. His uh, final outcome is good, but from the definition point of view, as this child required multiple surgeries to restore bony architect, this gap non-union was defined as a poor outcome. So which factors we assessed for adverse outcomes? We assessed age of the patient, site of infection, types of antibiotics used, and type of organisms isolated, immune status of patients. Based on MRI, whether there was presence or absence of soft tissue abscesses, how many previous local surgeries were done without assessing and dealing with the pan-osseous disease, and what were the symptomatic days before first intervention. So these are the factors which we saw, and we found that only last 3 factors had statistical significance. They are found statistically significant. Rest of the things, age, site of infection, type of organism isolated, type of antibiotics, and immune status were not significant. 3 of our patients, like one had splenectomy, one had aplastic anemia, one had Gaucher's disease, but they all had good outcomes. And the type of organisms, say in the year 2006 to 9 and 12, we had less incidence of MRSA. So we had 33 patients had MSSA, and 3 patients had, or 5 patients had MRSA. So now that is a limitation of this study. We do not have ideal distribution of a causative organism. In current era, we see more MRSA infections, and they are more detrimental, and they are more severely affected patients. So we'll discuss these 3 significant factors. Presence of soft tissue abscess. We all know that the periosteum receives blood supply from the intramedullary nutrient arteries. But in the cases where they have intramedullary disease, these arteries get blocked with the septic thrombus. If there is presence of soft tissue abscess, the other blood supply of periosteum, which comes from the compartment, that compartmental blood supply also gets blocked. So in patients who have circumferential abscess as well as intramedullary abscess, they have blockade of extra and intraosseous blood supply by obliterating nutrient vessels. And this leads to devitalization of periosteum, and that periosteum is not strong enough to throw new bone or involucrum, and that we have noticed in most of these patients with gap non-union. For an example, this patient who had infection with pathological fracture and pouring pus through the wound, as you can see here, and he was treated elsewhere with a local debridement by general surgeon. And with this X-ray, now there is probably impending sequestrum here, but one would think that let me do a debridement, remove this pus and splint it, and it will heal well. And that's what we did. We did an antibiotic mixed nail probably and a fixator because there was pathological fracture lying way high up. And as you can see, in due time, it ended up into a gap non-union. So the bone around this part, the bone around the circumferential soft tissue abscess, although the proper debridement was done, the periosteum was not strong enough to form the involucrum, and this child ended up into a gap non-union. So now down the line in my practice, when I see such X-ray, when the X-ray is looking like this and MRI is showing this picture, I would like to forecast, or I would like to warn the family that there is circumferential soft tissue abscess, and there is a chance that this bone may get resorbed. So your child may need a series of interventions to restore the bony architect. And earlier on in my practice, I always said that once we debride, once we remove the disease, this will heal. But now we can forecast based on this MRI finding. So in patients who had poor outcome, we found that 75% of patients had presence of soft tissue abscess besides the intramedullary abscess, while it was only in 20% of patients who had good outcome. That's how this factor was found statistically significant. Number of previous local surgeries. Earlier on, the soft tissue abscess was considered the disease of general surgeons to deal with, and they did not diagnose or investigate those cases further. When they see an extremity abscess, they always thought it's just an abscess, you drain it. But as we all know, that osteomyelitis will keep on draining, and those patients who undergo multiple interventions, they will come to us for definitive management. So these patients would end up into gap non-union because there are multiple local repeated treatment without investigation and treatment, pan-osseous disease. And so the pan-osseous disease will keep on draining from your surgical site, and it will eventually violate the periosteal health responsible for the gap non-union. So what we found in our 12 patients who had poor result, they had 19 surgeries done before they came to us, compared to only 5 surgeries in 18 patients who had good outcomes. So less number of surgeries and less local debridement, the periosteal health will be more preserved. And symptomatic days before first intervention, we found that poor results, patients had more than 6.5 weeks elapsed. So we applied this Kruskal-Wallis test here with our help of our statistician, and we found that as the duration of symptoms before first intervention increases, the chances of poor outcome also increases. So over-reliance of antibiotics by pediatric colleagues, by changing different types of antibiotics, does not help. You have to decompress the disease, and you have to let the antibiotics flow in by timely decompression. So there was only one outlier in good or fair outcome who had presented at 12 weeks, but still the child had good outcome, while most of our poor outcome patients presented to us after 6 weeks. They had first surgical intervention after 6 weeks. Now, this paper had many limitations because we partly relied on history given by the patient or the primary surgeon. In many instances, the primary surgeons referred these cases to us, and so we had honest conversation with them, and we plotted all those data. And few patients were still undergoing treatment for restricted motion or chronic sinuses. So some of these good patients may end up into fair outcome. Good outcomes may turn into fair outcome because the average follow-up was 2.5 years. And as I mentioned to you, this based on the causative organism, MRSA number was fairly less. So we do not know that in current era where we see almost 50% of our osteomyelitis patients had MRSA. So this was a bit older paper. So how to apply this in our practice is different, but this will definitely give you a clue that how to forecast the outcome. So conclusion of this paper is over-reliance on antibiotics should be avoided. That's one. An MRI of the bone is recommended to identify the soft tissue abscess and pan-osseous involvement. Sometimes due to the want of the economic constraints, we may not do MRI, but if you fail to decompress the disease completely, these children would require multiple surgeries, and cost of that surgery would be more than an MRI scan. And medullary decompression helps in influx of the antibiotics, and it should be done safely. We have received a lot of patients where there were only multiple drill holes were done in the metaphysis, or a small window were created, and those patients had kept on discharging pus. And so we always thought that how we can decompress the whole canal without jeopardizing the bone health. And since we started using giggly saw wire in associated medullary decompression, we had good result. But as we had found very surprisingly good results, we did not have any controls, because we always treated with intramedullary decompression starting from 1 year to 14 years. Earlier on, we used to use reamers, but now we found that it is so easy to negotiate a giggly saw. So we have used it in bigger children as well. So I would like to conclude that red flags to remember while treating chronic osteomyelitis in children is presence of circumferential soft tissue abscess on MRI, lapsed symptomatic time of more than 6 weeks before first intervention, and multiple previous local debridement without intramedullary decompression. If you find all these factors, then you should warn the family that this child may need more than one intervention to restore the architect, because their child is unable to undergo a gap non-union due to the course of the disease and not because of our intervention. Now, let me talk. Some of my fellows asked that you talk about giggly saw wire assisted. So I'll take you through that technique. The basis of this is when we used to use a solid reamers, we could not reach to the pan-osseous disease, or our reamer would touch the opposite cortex, while giggly saw is a very flexible wire, and its loop can be bent and compressed so that it can use for the scraping of the medullary canal. Trying to use a solid reamer may fracture the already weak bone of young children, so it should be avoided, and it is difficult to make entry. But once you start using giggly saw, you will see it will make its path nicely. You can negotiate giggly saw wire in the medullary canal very nicely, and then you can turn it in different direction and scrap the medullary canal, and you can decompress it, and it should be followed by putting a infant feeding tube and lavage. So this is a very helpful technique we have found in our practice, and I'll show you one case and surgical technique video. So this is a very young child, just 1.5 to 2 years. So they are very small bones and difficult to use the solid reamers. He presented with fever, inability to bear weight, and swelling along proximal tibia, and he didn't respond to IV antibiotics. X-ray showed lytic lesion in the proximal third. We got an MRI which shows the diffuse edema all across the metaphysis as well as the diaphysis. I hope you can get it. And there was circumferential, there was a long-standing abscess, as you can see. And in this 2 years old, it was difficult to decompress, but there was presence of diaphyseal disease. So we go with the maximum involved site, proximal tibial incision, and you go through the subcutaneous plane. And as there was fluctuant abscess, we aspirated this for the culture of the pus. And once you do it, then you go down to the bone. You see the periosteum and subperiosteal space, and you remove the subperiosteal abscess, and then you reach to the bone. So and bone, you see how in the vicinity of growth plate you are. You have to safeguard the growth plate. Make multiple small drill holes. Make sure that you are not drilling the opposite cortex. And with a small window, you join these drill holes with a small osteotome, and take out the small window, so that your small scoop can go in, and with the help of a scoop, you can directly decompress the medullary canal. When I do decompression or scooping, I try to make it like a giant cell tumor. So I would like to take out all the medullary content, because that leads to a decompression, and that will open up the nutrient vessels, whatever thrombosis it has. And one should make sure that you are not in the you are not in the near the growth plate. Now you take the giggly saw wire loop. If the window is very small, you can compress the loop. You can bend it a little bit so that you can scrap all the surfaces. So with a plier, you compress it and bend it a little bit, and you will see that you are able to negotiate it very easily like this. Initially, you will feel some resistance, and then it will make its own way once it reaches to diaphysis. With a simple hand or an artery forceps, you can put it, and then you see in the image intensifier, once you reach the desired area of distal metaphysis, you start moving to and fro. You can do it with your artery forceps, and as you can see, this will help in scrapping the medullary canal. Then you rotate the wire, and you scrap the different walls of the medullary canal, posterior wall, medial wall. And once you do it, you safeguard the skin while you are doing this scrapping, so you don't injure it. And then you put a infant feeding tube of appropriate size, and you have to lavage with a copious saline. You have to lavage till you see a clear fluid coming out. So now you see how much muck or how much debris is there inside the medullary canal, which we cannot decompress or debride by small window. But once you do a giggly saw assisted this, and now you will see how much muck is coming out. See, so all this debris and all this infected content, and sometimes you will also see some sequestrated small bone pieces coming out this way. And you keep on doing a lavage by withdrawing a little bit so that all the sequestrated pieces would come out till you receive the clear fluid. So I'm withdrawing it a little bit, and I'm lavaging it till I receive. Still, I'm receiving some blood, but irrigation is done till the clear fluid retrieved. Usually, for a young child like this, around 100-150 ml is enough. And once this is completely cured, there is a periosteum and there's a fascia. So we do not suture it. We just make a simple skin stitches interrupted. I don't take subcuticular stitches, where sometimes you need to open it up. And there's 3 months follow up. We give plaster for 6 weeks, and then PTB brace, and there's 1 year follow up. The child had complete healing. Yeah, so this was all about this paper and about the technique. And I would invite the questions from all of you. One question: did anytime the giggly saw wire broke while inside the medullary? Yes, once we had an incident that giggly saw wire got broken inside, and we realized that it was lying a little bit up, then my artery forceps could reach there. So we could not retrieve it. We decided that if the patient has active infection on the follow-up, then we may retrieve, but otherwise we will leave it behind. We explained this to relatives, but fortunately this child had nice healing without any subsequent signs of infection. What we realized that giggly saw wire, if you are doing very infrequent debridements, so ask for the new wires. That happened because we had a bunch of giggly saw wire with us, and as the inventory gets older, they become weak. Or if your fellow or someone who, if you hold this wire with a very new artery or a plier, then you may weaken this wire. So always call for a new giggly saw wire, and there are good companies. There are, the local made wires may be weak. So use your this new implant and from a good company, because giggly saw wire can occasionally break. Now we have done more than 100 osteomyelitis cases, and it has happened in once in our patient group. Yeah. Do you have any further question? I'll stop sharing my screen. Yes. Hitesh, are you there or?
Yeah, I'm there. I'm there.
Yeah. So your critical comments on this paper.
Yeah, that's fine. But whether you did for everybody, it's a giggly shows or intramedullary, whether it is if the MRI suggestive is only the surrounding area is 3 centimeters, so you still go beyond that?
No. So these all are the pan-osseous disease, or the disease where the metaphysis as well as the diaphysis was involved.
Okay.
So based on MRI, if it's just metaphyseal disease, then you don't need to pass your giggly wire in the diaphysis. But these are the cases which were, most of them were treated once by either a general surgeon or orthopedic surgeon, where they made the drill hole and then still the pus is coming. So what I feel is, if the disease is local, which is the case in most of them, just the metaphyseal disease, then you don't need to use giggly wire. Then you can use your scoop and do the local debridement. But when you see the diaphyseal disease, then you have to use it. And what I also feel is, there are some patients who are neglected and the disease has migrated not only subperiosteally but also on the diaphyseal side, which we see usually in pan-osseous disease. Many surgeons, they just do drill holes. So I feel that we should do a more extensive decompression in those patients. Now, as I don't have, now this paper came back from many like JPO and many other journals, because we didn't have control, that what happens for a pan-osseous disease if you just do the local drill hole. So this is my feeling of, but there is no evidence behind this. But that's if there is some other center who are carrying out just local drill holes and they have MRI for all the patients before surgery, then it would be a good comparison, that whether my thinking is right or it's an kind of over treatment just based on my own personal experience. And I know that this paper has a lot of limitations, because I started writing this in 2011, 12. So I was also not pretty mature. And, it's a number of patients. There are so many variables, you would need a large cohort of patients to address all the factors. And then there are so many. But I know there's not a very nicely, there are some subjects where you cannot do, when there are multiple variables, you cannot do very good work at writing that paper. But the message, all the fellows who have studied with me, they have witnessed how we do it, and they are seeing the follow-up. So maybe if you come across pan-osseous young 2-year-old which keeps on pouring pus, you can try sometime and tell me your feedback.
Yeah.
Okay, so yeah, thanks everyone, and thanks for your input. Thanks Harish and Anil. Thanks for your presence. Thanks for sharing a new technique. Was there any difference in the outcome with use of giggly saw? Harish, as I mentioned, I did not have the control group, but if someone wants to take it, then we have this full data of all these 40 patients. And now we have all long-term things, because these all patients, the last patient enrolled was in 2014. So we have now follow-up of all those patients for more than 5 years now. Fine, Hitesh, thank you very much for your time.
Thanks, Maulin.
We'll call you again.
Thanks, Dr. Hitesh.
Nice to see you, Harish. Good.
Nice to see you.
All well in Bellary?
Yeah, we are on the declining phase, but still on
nice.
Higher side.
Yeah.
Okay,
see you
thank
then.
you. Bye. Take care.
Bye. See you. Bye, Maulin. Bye.
Bye. Take care. Thanks, everyone. Bye-bye.